So that brings us on to our next conflict.
Can you control for treatment?
Yeah, good point. Nearly everybody in this had DHA piperacin. The interesting thing is how you control for primaquine. I'll show you a couple of those slides. They're a way, the data set is so large that we can actually do the subgroup analysis, but it's a good one. This is confounded, and this is my next point. So this is a conflict between laboratory scientists and clinical epidemiology. Of course, we all deny it, but it's absolutely true. And I always get accused of, I just don't think sometimes that we appreciate. As a clinician, I never appreciated the work that went into developing an assay in the lab until I actually met Brendan and worked across the bench from him at WeHi. And I'm a very bad laboratory scientist, as Brendan can ascertain. But you have no respect for that in terms of the work that goes into doing the lab. And neither do I sometimes feel that people have respect for putting together some of the epidemiology. And this is the data set that we had, over 1 million people, linking that in with the laboratory and the pharmacy records. That took, the analysis actually didn't take so long. We had Julie Simpson helping us to do those fractional curves. But actually to put that data set together took nearly 9 years and takes 47,000 lines of code to bring it together and cleaning it and merging it and cross-referencing it. That's a huge amount that isn't immediately transparent. And yet, people look at clinical epidemiology and they immediately say it's association, not causality. You're just mucking around. It's confounded, as you write. It is confounded because there are lots of other things. And you just got a data set and you're doing a bit of spurious data dredging. There are elements of truth in that, but likewise, we'll throw a hand grenade back at the laboratory sciences and say, for God's sake, what you're doing is esoterical. There's no grasp on reality. You have irrelevant timelines to produce a vaccine that will be in 40 years' time, and you don't like leaving the coffee bars. I went to a nice coffee bar this morning, but you don't like leaving the coffee bars in Melbourne because, that's where it's more comfortable. So how do we reconcile that? It's true, there's got to just be respect that actually what we're trying to do is take upstream science into clinical scenario, and more than that, we want to impact health at the end of that, and each of those take different skills. So it is a conflict, but my God, it should be a collaboration, and somehow we have to break that down. So anyway, going back to Papua, we did initial clinical studies were extraordinary. I did one of the hardest studies ever done in 40 patients there. With standard treatments, chloroquine for Vivax and chloroquine SP for Falciparum. 3 kids ended up in hospital. We had 65% failure rates, and we couldn't stop the study because if we stopped the study, they would go back and they'd be getting exactly the same treatments through their clinic. So we felt, well, at least if we continue the study, we can monitor these kids. And then while we were doing that, we managed to get DHA piperacin licensed through FDA. And we implemented that. Meanwhile, Nick and the Moru crowd were doing this quinine artesunate trial, and so there came an amazing time in about March 2006, where we were able to change policy. And these are the pharmacy records, and this is chloroquine, quinine, and then changing to DHA piperacin, the blue lines. This red line is primaquine. And this was quinine changing to intravenous artesunate. It all happened in a few weeks in March 2006. Anyone been in those policy-making decisions? It's extraordinary. They last forever. The air conditioning doesn't work. There's pink crimpling curtains. It takes time. But actually, when the National Malaria Control Programme was part of your studies, they are actually part of the advocacy. We changed policy before this was published in the Lancet to intravenous artesunate, and actually the whole of Indonesia went to a combined policy of DHA piperacin, which is our local ACT. We're writing this up at the moment, but you can see that actually overall the outpatient referrals with malaria rose, and that's because the population began to increase. But what is really gratifying is that the inpatients, almost there's the impact, the inpatient malaria went down considerably. This yellow line is the proportion of malaria due to Vivax, and I'll come back to that in a sec. But we saw with the implementation here a massive decrease in the number of patients who are anemic and the number who actually required admission. And so lots of really lovely figures, halving of PF incidence, third of PV incidence, reduction in admissions, 3 times. We also were one of the first places to use DHA piperacin in pregnancy. And we decrease, or we associated, I better not say we decrease, a 3-fold reduction in perinatal mortality and a reduction in vertical transmission and a reduction in low birth weight. So fantastic, it's wonderful to see. But what you do see out of this is a big but. There's been a gradual and unrelenting rise in the proportion of malaria due to Vivax. It was around 20% and now nearly 60% of the malaria that we see is due to Vivax. And we're not the only people to have shown that. That, I think anybody who's worked in Asia gets the same sense. These are the national figures over the last 10 years, 12 years. Nearly all the countries are reducing malaria. It's a very heartening reduction in malaria throughout Asia. But wherever you go, you see this reduction in Falciparum and a relative rise in Vivax. And we saw that also in Brazil. Here, Falciparum going down, but Vivax rising, and also in Colombia, and we've seen the similar sort of data in Papua. So the challenge there is, of course, ACT, DHA piperacin hits the blood stages, it doesn't hit the liver stages. And if you're going to do that, you have to have a drug that hits the liver stages, and the only drug we have is primaquine. We've been using it for 60 years. We still don't know how it works. We still haven't optimized its treatment, the treatment strategies. And of course, if you have G6PD deficiency, which is present in 400 million people in the world, you have a risk of severe hemolysis. So it's a mess. I call it the Vivax Paradox. The only drug we have to kill hippozoite stages is primaquine, and to prevent P. vivax recurrence, anemia, and associated morbidity and mortality, relies on a hemolytic drug that's potentially fatal. It's quite an interesting risk-benefit. This is some work from Christine Luxemburger, and this is the hemoglobin following an acute episode of malaria. It dips down and then it recovers by 63 days. If you give primaquine, you're in these black dots, and actually you begin by having worse anemia. If you don't give primaquine, by the time you get up to day 63s, you have better anemia. So you're damned if you do, you're damned if you don't. How do you work out the risk-benefit of that as a physician with a patient in front of you? It's not good enough to just be too scared to do anything. I'm not going to treat them, because actually the downsides of not treating them, I believe, are potentially fatal. This is a lovely piece from the great and the glorious at WHO. Nevertheless, the advance represented by the introduction of primaquine is not sufficient. The group recommends intensive research be carried out with a view to developing an anti-relapse drug free from side effects and radically curative at a single dose, or at the most a 3-day treatment regimen. That was 1963. And where have we gone in 70 years? Not very far, to be honest. And the other thing is that we give a 14-day regimen unsupervised. I'm an ID physician. I have never got my kids through more than about 4 days of antibiotics. By day 5, we all give up, especially something 4 times a day. So primaquine is not surprising. This is again data from the dirty data set. And when you follow people through who did and didn't receive primaquine because of out storage, actually you look at the risk of recurrence. This is with quinine and primaquine in the early days, huge numbers, 5,000-6,000 patients. You see almost no difference. They're not taking the drug, I'm sure. I don't think it's that there's primaquine resistance here. I just don't think that they're taking it. And how can you expect people to take a 14-day cure when they're better in 3-4 days? So there's a whole agenda here, and I won't bore you with that, but I think it's one of the biggest challenges we face, not just for primaquine as an anti-transmission blocking in Falciparum, which is fairly simple. It's a low-dose, single dose. There's not much problem there. But in Vivax radical cure, and this is something that many of us working here, Jack's developing some beautiful tests for G6PD deficiency, and there is a whole agenda here that we need to work out. And we're preparing for tefenoquine, a single-dose drug now, an 8-aminoquinoline that you can take just 1 dose. But again, if you get it wrong, you potentially kill people with a hemolysis, and people are very scared about that. So how we prepare the way for something which is going to be curative and to achieve our end goal is a massive challenge. Right, every day. This is about our time. Any questions on that? Anyone awake? The end game. Right, so These two are another nice collaboration. This cuddly man on the right is, of course, Warren Buffett, and no one needs to be introduced to Bill and Melinda Gates. And a very sterling, elimination 10, 15 years ago was a very dirty word because of the failures and the problems they ran into the 60s. And yet, this was a huge challenge to galvanize people into action. No child should die from malaria. The only way to end death from malaria is to end malaria. Pretty stirring stuff, isn't it? And we should declare that the goal of eradicating malaria, because we can do it. And we know we can do it. We've done it throughout Australia, we've done it throughout Europe, we've done it in America, we've done it many places, and we're doing it now. So we know it's feasible. But that was very contentious. You know, it was distracting, we were getting away from controlling, we were shifting the emphasis. Money's come in, 40 billion from Bill and Melinda, another 40 billion from Warren Buffett, and you can feel it. You can feel the whole 10 years, last 15 years has been galvanized in terms of decisions. Not always the best things, but you know, there has been that impetus. So I'm going to run through a couple of things, very shallowly, I'm afraid, but about some of the challenges of what we're doing. And of course, it's access and delivery. There's no point in having a policy if you don't implement it in the field. And I know that many policy people here working on that, you know how difficult that is. When you make a policy in the public sector, it's hard enough getting them the supply and the drugs. And then you find out that actually 60% of people don't go to the private sector, to the public sector, to the private sector. And the public sector, private sector are quite happy to be giving chloroquine or anything, injections of quinine, it doesn't matter. This is the distribution, this is taken from Shun Mei Young in Cambodia. And this is what she gathered from the private outlets of little bags of drugs that people get. God knows what's in it. But that's what actually the reality. And so the reality is that you change policy globally, it's fantastic, and we all go home and sleep much better. But actually the proportion of people who actually get it at the front line is hopeless. And how do we change that? What you do see as we reduce malaria is a reduction in deaths, and it's very gratifying to go to malaria endemic areas and not see many deaths. Well, we hope. But certainly in these places that are eliminating, one of the first things you chop away at the mountain is the mortality. And that's a problem. I mean, it's fantastic, but it's a problem because as soon as it drops off the horizon for the National Malaria Control Programme, they've got other priorities. They've got dengue outbreak, they've got diabetes, they've got other things. Why waste all of that money on malaria control programmes when we have other more important things that aren't killing people? And this is a classic example in Sri Lanka that had 18 cases of malaria in 1966. They'd done it. And they took their foot off the pedal. And all hell broke loose because he had 300,000 cases by the 1980s and 90s. And of course, they live next to India and there's a continual flow, so they reintroduce. And then you've got non-immune population that then have epidemics. And there have been plenty of epidemics, one in Madagascar, another in Burundi, where malaria came back and actually devastating death rates. But Sri Lanka's achieved it. They haven't had any malaria cases now for the last 2 years. And they still come to our Malaria Atlas ATMEM meetings, which I'll tell you about, even though they have no cases. And they still have to maintain 2,000 people reading microscopies and doing their business. That's very challenging to maintain that level of commitment, especially when you live next door to somebody who isn't. And these cross-border issues are huge. Why on earth is Korea? Korea eliminated malaria. And of course, the only types of malaria that you get in Korea, it's no surprising it's in the demilitarized zone. So you can't choose your neighbours. India and Sri Lanka and spillage over. The burden of malaria in India is massive. You've got some of the states with 200 million people in it. They're countries or several countries unto themselves. So these cross-border issues are really difficult to deal with. And you have this is an appalling indictment on human greed. Which is counterfeit drugs and drug quality. So we deal with counterfeit drugs. When you go to some of the outlet places in Asia and you look at the pharmacies, you actually find maybe 40 or 50% of the drugs are counterfeit. And they're very clever. They even change the logo and they do it, and you can actually order the amount of drug. How much active ingredient would you like in your malaria tablets? I mean, somebody could sit at a table and do that, which is basically a death sentence to a child. It's just staggering. But it's not just about counterfeit, it's also about drug quality. So, you know, obviously we want drugs to be made in country, but sometimes the regulatory processes aren't appropriate, and the drug quality that you come out, even within, you know, respectable pharmaceutical, isn't up to scratch. And so that's a huge problem. And low levels of drug actually drive drug resistance and cause problems. And then the threat of drug resistance. I've got one slide on this, and we could fill whole conferences on this, and it's obviously huge. And artemisinin resistance is a massive concern and threatens to derail the whole elimination agenda if we don't move quickly. People say that we discovered that in 2008. We didn't. We had evidence of that in 2002 with delayed parasite clearance time in Palin. Very slow response, which is a shame on us and the community that people haven't moved quicker. And people are trying to rectify that now. But obviously, if that escapes along the routes into Africa and other places, there's a potential disaster coming. And here's a new one which has come up in the last few years. Well, it's not new, but it's rising in importance, and that's the asymptomatic carriage. We see malaria going down and the cases presenting at hospitals, but actually there are masses of people out there who have got asymptomatic carriage, and they don't come. So you have to shift from passive surveillance where the patients come to you, and now you have to go out, seek and destroy, active surveillance. And of course, it's like those things of the moon and Earth and Jupiter and bigger and bigger and sun. Here's a supernova, which is a subpatent parasitemia. People who are microscopy negative, but actually when you look at them under PCR, and maybe up to 6-fold higher. So again, that's going to be a huge challenge because these are the reservoirs of infection that we have to eliminate to actually exterminate the parasite country by country. So there we go. That is the world that we have at the moment. The red is places under malaria control, green are malaria free, and these are the countries that are eliminating. In fact, it's changed a little bit. Indonesia's declared a elimination strategy and elimination goal, and so has Laos and Cambodia, and recently even PNG in India. They're quite far away off that, but they've also joined that. And a couple of years ago, 2014, the Asia Pacific Malaria Leaders Alliance, APLMA, if I got that right, made a commitment to Asia being malaria-free by the year 2030. That's 14 years away. That's a tall order. And here's people ploughing in. Some people are nearly there. Bhutan, Sri Lanka are nearly there. Malaysia, Peninsula of Malaysia is almost there. And then the other countries coming one after the other. The last being Vietnam and probably Indonesia. Those are very challenging agendas to deliver. I'm not sure how we're going to do it. So one of the things is the Asia Pacific Malaria Elimination Network, which was set up by Kevin Rudd, God bless him, with about $2 or $3 million, and that brought the countries, 11 countries together, and those 11 countries are now expanded to 18 countries. And what we're trying to do is create a forum where we bring national malaria control programs at the centre, but we bring researchers. Burnet was one of the first institutions part of that, with John Reeder, who came, and now Jack and James are representing Burnet at APMEM. But many other research groups from not just from Australia, but worldwide. Networks such as the WARN and the Malaria Atlas Project Group. We have WHO, funders, industry, and trying to bring people into a forum where you engage upstream science into policy and then into impact. Policy isn't enough. It has to go further. It has to actually get into the field and impact. And so there are some lovely examples of global collaboration now, and I think some of those are best shown by the geospatial mapping exercises. Wonderful work by Malaria Atlas Project, where people are sharing their prevalence data. Very, very simple data that they're sharing, and they put them together, and they have a clever way of doing it, and they produce these hot maps, and I'm sure you've all seen these. And wonderful. You can see the hotspot areas across Asia of where it is, including to the receptibility to the parasite. Here they've also extended that into looking at G6PD deficiency. And we're doing a similar sort of thing at the Worldwide Anti-Malarial Resistance Network, where we're pooling everyone's data and now looking at hotspots. So this is with molecular surveillance with K13. You can actually identify the hotspots, and we call this smart surveillance. It means that you go in with a global strategy, you see where the hotspots are, and then you can focus your energy on going in there with teams to actually look at doing clinical trials or to look at interventions. And you can think that this might go down with host polymorphisms, bednet use, counterfeit drugs, and you gradually build this onion of informatics that allow you to model and prioritize where in fact you can make your biggest impact. And you can also gauge the success. It's difficult to do this in real time, but the idea is that we put the data out, not 10 years after the event, but we put it out in a much more timely fashion. And something like this is going to be absolutely crucial for having timely interventions. And it's big. This is the WARN collaboration, 268 research units in 68 countries. That's massive. So there's what we're aiming for 2040. I mean, this should have gone and we reached the 2030 deadline. But actually, you nibble down until you get the hotspots within central part of Africa and here. And that's challenging. I don't know how you find your inspiration. There are a couple of good quotes there I thought I'd give you. Can't look better than going for Goethe for some German inspiration as to why you should do this. So whatever you can do or dream you can do, begin it. Because boldness has genius, power, and magic in it. That's pretty stirring stuff, isn't it? And here's one from Jean-Paul Sartre. It says, commitment is an act, not a word. It's very true. We do far too much talking, going to meetings, and actually people should be staying at home and just getting on with the business. So it's about an act. Unfortunately, I don't think he was referring to malaria, because another quote which I found from him is, I am no longer sure of anything. If I satiate my desires, I sin, but I deliver myself from them. And if I refuse to satisfy them, they infect the whole soul. He must have been a great guy to have around the office.
That's so great.
And here's one. This is for Freya. I don't think Freya's here yet, actually. This is a Scotsman, and this is fantastic. I love this. Until one is committed, so you make an act that we are going to achieve something, there is hesitancy in the chance to draw back, always ineffectiveness. The moment one definitely commits oneself, providence moves too. A whole stream of events issues from the decision, raising in one's favour all manner of unforeseen incidents, meetings, and material assistance, which no man could have dreamt could have come his way. Of course, this is 1950s, it's politically incorrect, so I'll just change that. And this is 1951. The Himalayan expedition in 1950. Of course, it was a heroic failure. They failed. They succeeded 2 years later. And I think, that commitment is actually what should be inspiring us. And so if that is what we're going to achieve, which is in our lifetime, Bill Gates assures us he wants it to be done before in his lifetime, we have got a huge amount to do. Now, I'm going to be 86 in 2050. I don't know where I'm going at the moment. I'm going to be gone by then. Is there anyone in their 20s? I'm sure there are. Who's in their 20s here? Go on, be honest. Put your hand up. Yeah. Oh my goodness, a lot of you. Well, it may not happen in my lifetime or Brendan's lifetime, but it will happen in your lifetime. And that is an amazing thought. It's a human endeavour of a parasite that's literally shaped humanity and our own genetic makeup. To think that we will eliminate that within our lifetime is incredible. And I feel even a small part of that is actually what drives me, and I know for people who are into malaria here, it also drives them. So we can only dream that that is what we're going to achieve. Thank you very much.